To answer the question, what is the future of drainage and resection procedures for chronic pancreatitis, I think we have to look back and learn from the past and present. So what are the criteria of an optimal operation for patients with chronic pancreatitis? The operation should be, first of all, safe, has no or at least low mortality and low morbidity. Besides the request of low postoperative morbidity, there shouldn't be a relevant impairment of endo and exocrine function by the operation itself. In addition, the operation should be efficiently treat the symptoms and complaints of patient. They should be long-term pain-free. Since pain is the most common symptom in patients with chronic pancreatitis, the first efforts in surgical treatment address this issue. The first hypothesis on the source of pain is and was intraductal hypertension, which consequently led to the application of different kind of drainage procedures. Duvel as well as Partington, Pistow, Gillespie introduced their techniques already in the 50s. They tried to drain the pancreatic duct system via the tail after performing a left lateral resection and splenectomy. This was mainly done because they worried about complication when operating on the pancreatic head. However, these techniques didn't become accepted because of their insufficient pain relief in long-term outcome. Some years later, the lateral pancreatojejunostomy was introduced by Partington Rochelle. Due to a wide opening to the duct system, a sufficient drainage could be ensured, and this technique found worldwide acceptance and is still in use by many surgeons. Over decades, several outcome studies have been published regarding this technique, and all they showed that this technique has a low morbidity and low mortality and reasonable to good pain relief results. However, nevertheless, there are some individual reports on failure and need of reoperation after LPJ, like this one by Markowitz, who reported 15 patients, of whom 14 need a kind of resection and 1 an extension of LPJ. In addition, other hypotheses on the source of pain assumed an influence of inflammation inside the enlarged pancreatic head, leading to damages and changes on nerves and the release of pain-inducing neuropeptides. And this, of course, was rather favor a type of resection for the treatment of pain. When looking at preoperative symptoms of patients who got operated because of chronic pancreatitis, here are the results of our own study, which are comparable to those of many others. Again, pain is on top, but there are also a very relevant number of patients with symptoms related to enlargement of the pancreatic head, like jaundice, portal hypertension, or gastric outlet obstruction. It is obvious that a patient like this with an enlarged fibrotic pancreatic head mass cannot be sufficiently treated with a drainage operation. It's not well documented how many patients do have enlargements of their head and what the average size is. Unfortunately, most studies on surgical therapy are missing these parameters. However, these 2 studies have documented that this is a common and relevant problem. All the facts I've mentioned, the frequency of head-related symptoms, the failure of LPG, the new hypothesis of pain, and last but not least, the decline in morbidity and mortality of head resection led to and pushed the acceptance of resectional procedures, formerly reserved just for malignancy, now also for patients with chronic pancreatitis. The absence of malignancy and the efforts for preserving structures and function led to the development of new duodenum preserving techniques, also called hybrid techniques. Fry described a technique where he just added excavation of the pancreatic head to a normal LPG, whereas Beger described the technique with a transection of the pancreatic head in front of the portal venous axis, like is done in classic Whipple procedures, resected the head and leaves just a small slice of pancreatic tissue inside the duodenum. The Hamburg procedure and Bern procedures are mainly modifications of Frey. Hamburg added a V-shaped excision, and Bern just waves the opening of the pancreatical duct on body and tail. The Beger procedure allows easy and controllable decompression of the common bile duct, and therewith mucosa to mucosa bilioenteric anastomosis, whereas Frey and the modification of Frey just allow an opening of the common bile duct to the resectional cavity, and this can lead to biliary strictures in the late course and to the need of reoperation as it's reported in some studies. So these are again the level 1 studies, compared the new duodenum preserving techniques with the established pylorus or classic Whipple procedures. Regarding the early postoperative outcomes. The first studies published by Büchler and Spicki were able to demonstrate advantages for the duodenum preserving techniques for almost all functional parameters like endo and exocrine function, like quality of life, and even for pain control. Despite the small numbers of patients included, these very early promising results led to the wide acceptance of these techniques. Only our own study was not able to confirm these advantages in the early phase. However, now for at least 3 of these studies, long-term data available. By these data, it was not possible anymore to demonstrate any kind of advantage of the duodenum preserving technique. So both techniques are equally effective regarding the outcome parameters. There are also level 1 studies in literature comparing the different kind of duodenum preserving techniques to each other, like this one by Spicki comparing Beger versus Frey, or this one by Koeniger comparing Bern versus Beger. No significant differences could be demonstrated neither for early nor for late results. For the Frey procedure, which is certainly more applied around the world than the other duodenum preserving techniques, a variety of outcome studies are available, demonstrating that this technique is safe, it's effective regarding pain control, it's stabilizing the exocrine function. Only the natural cause of endocrine function impairment cannot be influenced by the operation. A small number of German studies could demonstrate similar results for the Beger procedure. Beger itself reported his own experience with more than 300 patients, and again he could show low morbidity and mortality, good results for pain relief, and the same results regarding exocrine and endocrine function like it was shown for the Frey procedure. A very challenging problem, which again raises up the question what technique is appropriate, resection or drainage, is extrahepatic generalized portal hypertension due to chronic pancreatitis. We have established an algorithm depending on whether there is a total occlusion or a subtotal stenosis as a reason for this hypertension. Patient with a subtotal stenosis should operate with a pylorus preserving Whipple or a Beger procedure and thereby get a transection of the pancreatic neck to ensure the decompression of vein and there was a normalization of blood flow and blood pressure. Whereas patient with a total occlusion should operate according to Frey or receiving LPG because a transection in this case, or even a resection of the pancreatic head would end up in a loss of collaterals and in an uncontrollable bleeding disaster. Just to illustrate, Here a patient with high stenosis of the portal venous axis. The stents after endoscopic treatment, unsuccessful treatment, are still in place. And 2 years after, the patient received a CT scan for other reason, and a normal portal venous axis could be demonstrated. On the other side, the typical patient with a total occlusion, 5 years after receiving an endoscopic treatment, unsuccessful, and now you can see the typical cavernous transformation, the collaterals. This patient received a Fry procedure, an additional lateral hepaticojejunostomy Y and room. In a study setting, we were able to demonstrate the feasibility of an interventional recanalization of occluded portal vein or superior mesenteric vein via tips. Just to illustrate this approach, the situation before intervention, the placement of the catheter, and then the revascularization. This patient received heparin via the catheter, which was kept in place till operation, performed 1 day later. We have published a study on 16 patients treated according to this algorithm and compared these patients to 169 other patients who got pancreatic head resection without having generalized portal hypertension, beside a longer OR time and a higher amount of blood loss. The other perioperative outcome parameters show no significant differences. Summarizing all the mentioned data for answering the question, what are the future of drainage and resection, and keeping in mind the criteria for an optimal operation, I would like to conclude a tailored approach as followed. Patient with a suspicion of malignancy and which have a large pancreatic head, which, like I would call it, frozen duodenum, should be operated with a pylorus preserving pancreatic duodenectomy. Patient with a common bile duct stenosis or with a stenosis of superior mesenteric vein or portal vein and who are not fit into group A should receiving a Bager, whereas patient who are not fit into A and B and have pain or recurrent episodes or a total occlusion should be operated according to Fry. Keeping in mind the late results of the level 1 studies, and by trying to simplify this approach, one could also conclude this two-arm approach nowadays, where the patients with a large pancreatic head and related symptoms should be operated with a pylorus preserving procedure, and the ones without having a large pancreatic head and have pain and recurrent episodes and have occlusion of the portal venous axis should be operated according to Fry or receiving an LPG. Just to illustrate it with 2 examples, this is a patient with a large pancreatic head mass, with subtotal stenosis, with a frozen duodenum and biliary obstruction, operated with a pylorus preserving head resection, and this one a patient with pain, recurrent episodes, which received a Fry procedure. Applying this tailored approach to our patient, out of 485 patients we operated on in almost 20 years, 361 received a resection, and just 99, so almost 20%, received a Fry or drainage procedure. I'd like to summarize. Over decades, several approaches have been approved for efficiency and safety. The mortality of these approaches is very low, in most studies below 1%, even for resections. There are no differences regarding functional outcome parameters between the different type of head resections. I think the most important conclusion, the selection should be made in relation to symptoms and morphology. I think we do not have a single approach for every of our patients. And for our community, For most of our patients, resection is the adequate choice. Thank you very much for your attention.